Good afternoon. So over the next 4 minutes, let's unwrap a case of invasive squamous cell carcinoma of the conjunctiva. A 35-year-old man presented with a painless swelling in the left eye for the past 10 months. It had already been excised twice. As you can see that it's a big 10 millimeter by 10 millimeter nodular, fleshy, sessile swelling with a lot of surface keratinization and feeder plus intrinsic vessels. It is encroaching upon the cornea as well, and upon rose Bengal staining, it stained positive. Now since we are in Bengal, does anyone know why is it called rose Bengal? Because in 1930s, the British scientists thought that the color resembled the vermilion used by Bengali Hindu married women, and it stings so much because it contains iodine. Well, a few things here, a few important things. We should evert the lid to see for any multifocality, and also for intraocular extension as quite probable in these cases. We should look for anterior chamber cells, any D-shaped pupil, gonioscopy or UBM should be done to rule out them. A non-invasive modality is ASOCT, which was done, which clearly shows a demarcation between the thickened hyperreflective involved epithelium, a breach in the basement membrane, from the normal epithelium, as corroborated by the histopath reports as well. As we know that OSSN is a spectrum that ranges from dysplasia to intraepithelial neoplasia to squamous cell carcinoma. When there is a breach in the basement membrane of the conjunctival epithelium, we call it a squamous cell carcinoma. We went about treating it with complete surgical excision with no-touch technique. 4 millimeter of healthy tissue margin, clinically determined, was taken on the conjunctival side and 2 millimeter on the corneal side. Double freeze-thaw cryotherapy was done to induce ischemic necrosis, and closure was done using cryotherapy and AMG. When the histopath report showed medial margin positivity, we had to continue on topical chemotherapy using mitomycin C, 0.04%, 4 times per day for 4 days a week for up to 4 weeks, along with lubricants. 6 months follow-up shows no recurrence till now. Now, what are the indications of non-invasive OSSN topical chemotherapy? It can be more than 2 quadrants of conjunctival involvement, more than 180 degree of limbal involvement, clear corneal involvement threatening the visual axis, positive margin post-surgical excision, or if the patient is unfit for surgery. Alternatives to mitomycin C are 1% 5-fluorouracil or interferon alpha 2 beta, 1 million international units, given topically or intralesionally, continued to 1 month post complete recovery. As we know with OSSN, the reviews must go on because the chances of recurrence range from 15 to 50%. Thank you.
Thank you, Dr. Arnab. Again, the question is, what is your take-home message?
The take-home message, ma'am, since it has been excised twice in a period of 4 months and had recurred to this extent with so much rage, therefore it is quite evident that it cannot be a benign thing. It has to be pre-malignant or malignant. So the differentials, which is among OSSN range itself, we can't call it anymore a CIN or in situ. It has to be a case of invasive squamous carcinoma corroborated by ASOCT and by histopathology.
So one is the diagnostic aspect. From the management aspect, what is your take-home message for this particular situation?
Since it is an invasive squamous cell carcinoma, no need of topical chemotherapy at first go. First go is complete surgical excision, no touch.
All right. Agree completely. So for a situation like this where it has been twice excised, looking at the morphology of the lesion, this looks like more like a nodular variant of OSSN,
yes.
which we know are more likely to go inside.
Yes.
I'm not sure if you did any UBM for this patient because we didn't have the picture.
We didn't do, ma'am.
So ideally, an UBM should be done for this patient, even if you are planning a surgery as a pre-op evaluation. ASOCT is not going to give a good picture in this kind of situation. Because of a lot of keratin, you are going to get the shadow.
Yes, ma'am.
So based on the UBM, you decide how much to excise.
Yes, ma'am.
You did mention you did a lamellar sclerectomy.
Yes.
But also you mentioned that you went in the episcleral plane. So if you are doing a lamellar sclerectomy, you are into the sclera. You are no longer into the episcleral plane.
No, ma'am. We had to do a lamellar sclerectomy, ma'am.
Right. So episcleral you are only when the lesion is limited
CIN,
to the
yes.
CIN. So when it goes into the sclera, you are into the sclera,
Yes,
not into the
ma'am.
episcleral.
Yes, ma'am. Yes,
space. And it's important to look at that.
yes, ma'am. Yes, ma'am.
So what will be your protocol for post-operative follow-up now?
Post-operative follow-up, ma'am, every time the patient comes, we should stain the cornea once to look for any SPKs or PE, because all chemotherapeutic agents cause LSCD or PE or SPK, that is one. Second is recurrence chances are very high. The other aspect is, which I am also confused about, is whether cryotherapy should be given on the scleral base itself, because many people do not give it. In this case, we had not done it, and there was no recurrence in 6 months.
Are you looking for any residual disease that may invade locally also?
Residual disease?
Maybe, how, are you sure that the whole of the mass has been, your margins were free when you
No, ma'am. Medial margin positivity was there, ma'am.
So,
That is why we had to give mitomycin C at least for 4 weeks, then 2 weeks of hiatus, then again we had to give it.
so besides your local recurrence over there, you need to also see whether it is invading. Sometimes these patients come back after years with invasion into the muscles,
Yes,
into the orbit. So
Yes,
you
ma'am.
have to be really alert to watch for those kind of things
Yes,
also.
ma'am. Yes.
And regarding the cryo, if intraoperatively you are finding any fixity of the base to the episclera or the sclera, a cryo should be done at the base also,
Okay, ma'am.
along with the margin.
Okay, ma'am. Thank you.
Thank you so
Thank
much.
you.